Okay, great. Well, welcome everybody. My name is Lisa Goldman Rosas. I'm an assistant professor in the Department of Epidemiology and Population Health, and also in the Department of Medicine in our Division of Primary Care and Population Health. And I'm really pleased to welcome you today to our fireside chat, Health Equity Research in Disabilities Communities. I feel like we have a lot to learn as a community in this area, and I'm personally really interested in hearing from our panelists today. So I'm also one of the steering committee members for HEAL. HEAL stands for Health Equity Action Leadership Network, and this was launched by the Office of Faculty Development and Diversity to build support and community here at Stanford for health equity research. Today's fireside chat is one in a series, so I hope you'll be attending all of these wonderful events. I will be moderating today with three wonderful panelists who I will introduce in a minute. And we hope that you will go ahead and submit questions in the Q&A, and we will be monitoring that, and we'll get to the questions at the end of each panelist's presentations. I want to first, before I introduce the panelists, thank the Office of Faculty Development and Diversity, especially Brenda and Magali and Jill, and to their leader, Bonnie Maldonado, for supporting this event. And I also want to thank Derek for providing the sign language interpretation today. Great. So without further delay, I'll introduce our panelists and then I'll turn it over to them. So first, we're going to hear from Dr. Peter Poulos. He's faculty in the departments of radiology and gastroenterology and hepatology. He's also the founder and executive director of the Stanford Medicine Abilities Coalition, a group composed of people with disabilities and their allies here at Stanford Medicine. Then we will hear from Dr. Ken Southa. He's an instructor in the Department of Pediatrics in the Division of Nephrology and works at Lucile Packard and the school and here at the School of Medicine. He devotes his time to a combination of patient care advocacy and research. He is also himself a formal dialysis patient and two-time kidney transplant recipient. Dr. Southa serves as the co-chair for the Stanford Medicine Abilities Coalition. And then we will hear from Dr. Holly Tabor. She's an associate professor of medicine here at Stanford and the associate director for the clinical ethics and education for the Stanford Center for Biomedical Ethics. And she's co-chair of the ethics committees both at Stanford Hospital and Lucile Packard. Her research focuses on ethical issues in genetics and genomics and has a new PCORI grant focusing on individuals with intellectual and developmental disabilities. And I'm excited to collaborate with her on that. So without further ado, I will turn it over first to you, Dr. Poulos.
Thank you so much, Dr. Goldman Rosas. So today I'm going to be talking about the role of providers with disabilities and health equity for people with disabilities. This storm that we had this weekend was the third largest on record since 1950. But despite that, we braved the wind and rain and went to a pumpkin carving contest. And my wife insisted that I wear a costume because all of the adults and children would be dressing up. But it turned out that I was the only person who dressed up in a costume for the entire party. So that was fun. And my kid's nose was running and he didn't stop screaming the entire time. So we stayed for about 10 minutes and then left. So that was an exciting Sunday outing. This is me in 2003, bicycling up a hill in San Francisco. I was a GI fellow at the time and an avid cyclist. One day, after rounding on my patients at Parnassus Hospital, I took off for what I thought would be an hour-long bike ride, but turned unfortunately into a 2.5-month hospital stay. I was paralyzed from the neck down in a freak accident and wound up in the ICU at San Francisco General. This is me there in my hospital room. And, I had taken care of other patients in these rooms. So I was like in my own ICU being cared for by my colleagues. I was transferred to Santa Clara Valley Medical Center, where I learned how to drive a wheelchair with my chin. But eventually, luckily, started recovering and eventually regained the ability to move and walk. And although it's not normal, it's certainly easier for me than it was before. And this is me on my Segway. You may see me like cruising around campus on this. I came to Stanford in 2004 to do radiology. I had a newfound empathy and connection to my patients when I went back to the GI clinics, but it was just simply too difficult to examine patients and to manage like a clinical workload independently. And I really wanted to work independently. And so radiology allows me to do that. All I need is a microphone and a computer. And so I finished my training in 2009 when I started on the faculty here. I spent my first few years as the associate residency program director, and then eventually was looking for something else to do. I saw a lot of disability efforts were arising on campus, but diversity events were being started, but it didn't appear that disability was being represented. This diagram here on the left, you see a lot of people of different gender, race, ethnicity, religion being depicted, but not really disability. And that's what it looked like to me. Even on the bottom right, my own department had a radiology diversity initiative with this great infographic with 2 people with visible disabilities, but there wasn't actually somebody with a disability on that committee. And so that was my first kind of foray into diversity work, volunteering for this committee, which eventually turned into, after some twists and turns, my founding the Stanford Medicine Abilities Coalition. And this is a photo here of our very first event. Here's Dr. Sutha in the front row. We didn't know each other yet, but we would come to know each other quite well by the end of this. And so, for me, I didn't know much about disability and certainly about disability health equity. And I don't really consider myself a health equity researcher of any stature at this point. I'm just starting in this direction for disability advocacy and advocacy for our patients. But that's the dual mission of the Stanford Medicine Abilities Coalition. And they're directly related. We feel like the inclusion of more disabled people in healthcare, doctors, nurses, PTs, OTs, any and all employees of our system, that people with disabilities, because of their unique perspective, will improve care for patients with disabilities. And so that's what we are advocating. And so we'll talk a little bit about what it looks like for our patients with disabilities. And unfortunately, the status is not great. It seems like whatever marker you look at, there are inequities. On this graph here from HHS shows that disabled people are more likely to be unemployed, more likely to be victims of violent crime, more likely to have cardiovascular disease, to be obese, to be a smoker, to engage in no leisure time physical activity, to be less likely to be current with their mammogram, to not be receiving Medicare care due to cost. And I mean, the list goes on and on. Pap smear rates, colorectal cancer screening, likelihood of undergoing lung cancer surgery for an operable tumor. There's a lot of inaccessibility in terms of medical equipment and clinics, and frank unwillingness to provide care for patients with disabilities. And there's a great article that came out a few weeks ago in the LA Times about how modern medicine neglects disabled mothers. And this article talks a lot about inequities like pregnant women in wheelchairs being unlikely to be weighed throughout their pregnancy. Now, blind women are 2 times as likely to have a C-section, et cetera. And so it's not great. And what about disability amongst ourselves, amongst providers? Well, people with disabilities are the largest minority in America, ranges from 1 in 7 to 1 in 4, depending on what exactly you're looking at. But yet only 5% of medical students have a disability. And then when you get into practicing physicians, you're looking at around 3%. And so we feel like this is a big issue, having little representation of a huge slice of the population. And we're often left out of diversity efforts. So we feel like, from what we've been through, we've demonstrated grit and perseverance. We have a unique perspective on life and health, being on both sides of the curtain or both sides of the stethoscope, however you want to phrase it, that we are equipped with disability, cultural humility, and cultural competence. And our mere presence in healthcare creates what has been termed an upward spiral of positive or informed information about those with disabilities. That is, if you have a colleague with a disability, then and you have an equal status relationship with that person, that decreases the stigma of disability, and then also translate to decreased stigma of our patients with disabilities. And so it's imperative that we be included and visible. It's been shown in research studies that physicians with disabilities have this deep understanding, and their personal experience of living with a disability affects their interactions with their clients, that they're able to build rapport and advocate for them and apply creative approaches to problem solving. And it's also been shown that patients have positive views or opinions about providers with disabilities in terms of their personal maturity, enhanced client-centeredness, role modeling, empathy, a more comprehensive understanding of the healthcare system. And so, one of my first forays here has been my participation in the COVID journey. Dr. Malathi Srinivasan and I are co-PIs on 2 grants, one from ChemH and the other from ETS. And those are looking at the experience of patients with disabilities in the setting of telehealth and COVID-19. So we're looking at 5 groups: blind, low vision, deaf, hard of hearing, cognitive disabilities, mobility disabilities, and autism spectrum, to see how this switch to telehealth has been affecting them. And we're currently in the process of interviewing these patients and about to start analyzing the data. And the preliminary results are very interesting. And so that's one project. We're working on other projects. We have a podcast. We got a grant from the Department of Radiology to expand this Docs with Disabilities podcast that was started by Dr. Lisa Meeks. And we interview physicians and other healthcare providers with disabilities to talk about their road issues for other upcoming or up-and-coming students or doctors with disabilities, and how we can improve patient care for our disabled patients. And we also, recognizing a dearth of mentorship and community, have started a mentorship program with these two national organizations, the Medical Students with Disability and Chronic Illness, which was started at Stanford, and the Society of Physicians with Disabilities, to try and improve retention and help disabled students navigate the system. We've had 2 conferences on disabilities that were attended by over 1,000 people. Most recent one had attendees from over 39 countries. Just some sample lectures that we had, like the power and benefit of disabled professionals in healthcare. We did breakout sessions talking about medical ableism with disabled patients, and disability, healthcare gap, and challenges to culturally humble care. Last of all, just say like these are sort of our buckets in which we function. And I would just highlight also down in the bottom right in the health equity space that we have formed a patient family advisory council, pairing up 11 disabled patients with 6 staff members to meet at the table and to talk about the disabled experience and to work within the system to improve it. And that's been very gratifying to see empowerment of our patients. And so, yeah, that's my story and what we've been up to. And now I'd like to pass it on to Dr. Sutha. Thank you.
Thank you so much, Dr. Poulos. What a wonderful presentation, and to kick us off in such amazing work. I'm really struck by the size of the population that you described. And I think if you add caregivers to that, we're an even larger population. Wonderful. So Dr. Sutha, you are next.
Hey, thank you so much for the introduction and for the lead up, Dr. Poulos. It's always tough to follow your presentations. As mentioned, I am Ken Sutha. I'm an instructor in pediatric nephrology over at Lucile Packard. Follow me on Twitter. I'll be following a similar format to Dr. Poulos' presentation. As mentioned, I take care of patients with all different kinds of kidney disease, including those on dialysis and needing transplants, but the bulk of my time is actually spent in the lab doing research, basic science research, in developing organoid models of kidney disease, thanks to support from the Department of Pediatrics and the Bridge to K instructor program. I've been doing that now for about 2 years since completing my fellowship here. But as well, of course, we always like to frame our presentations with some sort of patient vignette. And so not an uncommon scenario that we'll see in clinic. There was a patient that presented with proteinuria at the age of 10, something like nephrotic syndrome, not that uncommon in pediatric nephrology. However, this patient didn't respond to the normal treatments with steroids, and so underwent a biopsy, a kidney biopsy, to figure out what the underlying cause was, and was found to have FSGS, focal segmental glomerular sclerosis, which basically just means that there's scarring of the kidney. The doctors were able to manage the proteinuria and reduce it, but not completely eliminate it, by putting the patient on an ACE inhibitor that could slow the decline of the kidney disease and the GFR, but not completely stop it, to the point where by the time they were graduating from college, they knew they would need to go on dialysis or receive a transplant in order to survive. Based on the introduction, it may not be much of a surprise to you, but that patient was me. And by the time I was in my second year of medical school, back in 2006, it was time for me to receive a kidney transplant. Thankfully, my dad was a match, and so I received a preemptive kidney transplant in 2006, sorry, not 2016, at the end of my second year of medical school. After the transplant, things went really well. I was able to return and take step 1 with the rest of my class on time, and then started grad school for my PhD. I even was able to volunteer at a camp for kids with kidney disease and on dialysis and all kinds of transplants, and even went on to compete at something called the Transplant Games, which is basically like the Olympics for people with transplants, even winning some medals. After that, graduated from medical school and graduate school, went to residency, became a pediatrician, and ultimately a pediatric nephrologist. Oftentimes, the story kind of might stop here. In stories about chronic illness and disability, we oftentimes like to focus on positive things and stories of overcoming. But as we all know, in the medical field, that's not always the case, and that wasn't the case that was the case for me as well. Transplant is a treatment and not a cure, and it comes with its own kind of challenges along the way. Because of the immunosuppression that I needed to maintain my transplant and prevent rejection, I was also at risk for many different kinds of infections. And because of those infections, my medications had to be reduced. And I ultimately, that then put me at risk for rejection. So about a decade after receiving my transplant, I needed to go on dialysis. This time, I was fortunate that I was able to do a form of dialysis called peritoneal dialysis, which I could do at night, every night. That allowed me to continue working full time, even while I was doing my fellowship here at Stanford. There were, of course, a lot of things to balance with that in terms of taking my medications, trying to work in doctor's visits around my call schedule, et cetera. Thankfully, after about 2 years on the waiting list, I received this time a deceased kidney transplant and have been doing pretty well since then, and have been able to spend time doing advocacy around kidney disease and raising awareness about organ donation. However, during all that time, I never really identified myself as being a person with a disability. I had always grown up thinking that I had a chronic disease, kidney disease, and that had some sort of impact on me. But maybe related to my own internalized ableism, I never adopted that label of disability. However, after coming back from my second transplant was around the time that Dr. Poulos was forming SMAC. And as we saw in that picture, I went to that first meeting, that launch meeting, and really expanded my mind and learned a lot more about what it means to be disabled and what the diversity of disability. Oftentimes mobility disabilities and sensory disabilities come to mind first, but it's really much more broad than that, including learning disabilities, chronic health conditions, neurodiversity, and mental health conditions as well. And really, as Dr. Poulos really well laid out, in the work that we're doing with SMAC, we really think that we need to have a culture shift in the way that we approach disability, and that disabilities, that people should be celebrated and recruited for their disabilities, their experiences, and the perspectives that those experiences bring, and not despite those experiences and those disabilities. And like all things health equity, there are many intersections with other kinds of issues related to health equity, including between ableism, anti-LGBTQ bias, racism, and sexism. And so when thinking about how all these things affect all of us, even if you don't personally identify as having a disability, there are the principles of intersectionality and allyship that kind of come into play here. And the thought that in this general fight for health equity, I've heard it said that a rising tide raises all ships. And so by making the system better for some people, we're making it better for everybody. That also goes into the idea of universal design. That's the idea, again, that when we're implementing changes to the system that are meant to address problems faced by some, that really we're improving things for everybody. The common example of this are curb cuts in a sidewalk. So originally intended for people, for wheelchair users, to be able to have easier access between the street and the sidewalk. But we find that those can be beneficial for everybody. And then even in the times of the COVID pandemic, we've seen how the switch to telehealth has really been beneficial for many people, many of our patients. And one thing, though, is, as Dr. Poulos mentioned, is that we still don't have a great understanding of the degree to which this impacts people within the healthcare system. And even though we know that including people with disabilities and other chronic health conditions can be beneficial for our patients, we don't fully understand all the challenges that they might be facing in being able to pursue careers in healthcare. We were able to look at this a little bit along with the Commission for Justice with a survey done last year, the Justice, Equity, and Abilities Survey. This was able to garner over 3,300 responses. Again, not focused specifically only on disability, but on lots of larger issues related to justice and equity. And so we think that these results are hopefully more generalizable because there wasn't this sampling bias of only people invested in disability replying to it. Some preliminary results from that study have shown that disability is common here. that 26% of people at Stanford Medicine have a disability of some sort, even though most of them don't identify as being disabled. And of those people that are disabled, 80% are operating without accommodations of any kind, because of perceived barriers like costs and unclear benefits to getting those. During my time on dialysis here as a trainee, I never sought any kind of formal accommodations, not because I wouldn't have potentially benefited from that, but because I didn't know what the process was to get them. I didn't know what kind of accommodations I might have benefited from. Additionally, and something that SMAC has been trying to address, is that people with disabilities here at Stanford Medicine don't have a strong sense of community. And because of that, all these things together take a toll on satisfaction and sense of belonging for people here with disabilities at Stanford, even more so than some of the toll that's taken on underrepresented minorities. As I mentioned, we've been trying to break this down a little bit more. And because of my experience as a trainee here, I'm also particularly interested in the experience of our trainees with disabilities as a more vulnerable population. Looking at residents and fellows, we see that, again, we follow similar trends within our resident fellow population as we do overall, with about 1 in 5 either having an ADA-defined disability or identifying themselves as being disabled. This is again in line with the data that Dr. Poulos quoted nationally for people with disabilities. Although it does seem like maybe we have a little bit better representation than the single-digit representation of practicing physicians that has been found for practicing physicians. But again, as we stated, many of these people with disabilities, even though they could potentially use accommodations, have not been requesting them. And so we're trying to drill down into why exactly that is, and to see what we can do to ameliorate that situation. As Dr. Poulos mentioned, one way that we're trying to address this is trying to increase visibility for physicians and other healthcare workers with disabilities, and creating more of a sense of community and support. As he discussed, we have developed a mentorship program in combination with the Society of Physicians with Disabilities and medical students with disability and chronic illness. We launched a pilot program last fall or winter, I think in January, to create mutual mentorship program for persons with disability. In this, we have a monthly meeting from people here at Stanford and trainees nationally as well, and practicing physicians with disabilities, where we go over different topics related to disability, like disclosure, seeking accommodations, sort of navigating the legal process that's associated with disability. And then we have breakout sessions. And one of the most striking things about it is that with these breakout sessions, the sense of community that's been developed amongst these trainees that are able to participate, with people often staying on the Zoom to talk over an hour after the official end time of the mentorship program. And we've even gotten feedback that people have decided not to drop out of that they had been considering dropping out of their programs because of barriers that they were facing. But after finding our sense of community that through this program have decided that they now have resources available to them to be able to stick this out. We're working at expanding this, and we've been very fortunate to receive a grant from the Teaching and Mentoring Academy in order to expand this. Thanks in large part to a lot of work from one of our very talented MSTP students, Suchita Rostagi. With that, I'd like to thank my division for all the support that they gave me throughout all of the process. There's no way I would have been able to navigate this without their support, as well as my funding sources. I'd also like to give a brief shout out for our events that we have coming up. There's 2 more for this. We've been doing events throughout the month of October for National Disability Employment Awareness Month. You can scan the QR code or visit our Twitter for more details. And last but not least, of course, I'd like to thank my donors, particularly my dad, who is my living donor. And with that, I'm happy to pass it off to Dr. Tabor.
Wonderful. Thank you so much, Dr. Supa. And thanks for sharing about the trainee resource that you have. You're clearly doing a huge service for our trainees. All right, I want to remind everyone before I pass it over to Dr. Tabor to please go ahead and submit your questions in the Q&A. I see we have one from Whitney Wood. Thank you so much. So go ahead and put those in and we'll get to them after Dr. Tabor's presentation. Okay, over to you, Holly.
Technical difficulties, we'll get it. Hold on. Can you see that now?
We can see it and we can hear you, yeah.
Great. Okay, sorry for that. I want to thank you very much for the invitation. It's always an honor to get to speak for anything that Heal organizes, and also an honor to speak with Dr. Poulos and Dr. Sutha, and hard acts to follow. I want to talk a little bit about my personal experiences and also how that's informed some of my work, focusing on inclusive healthcare for people with disabilities. I'm an ethicist, although I'm trained originally as an epidemiologist and then got training as an ethicist. And so I think about a lot of the work that I do through the lens of sort of ethics and why it's important for us to do certain things and avoid certain other things that cause harm for both individuals and populations. I like using this photo in presentations that I give because I think a lot of us share something that I say, which is I wear many hats. So I have my hats as a faculty member and as an employee at Stanford, as an ethicist and so forth in all my professional roles. And I also have hats in my personal life, particularly as the parent of my two children who are 20 and 17, both of whom have different kinds of intellectual disabilities. And so I'm going to be talking a little bit more about intellectual and developmental disabilities, which are another type of sometimes it's called invisible disabilities. This is a picture shared with permission of my son, Colin. It was taken a couple of years ago. He's a tuba player. He's now 20 years old. Colin was diagnosed with autism when he was 3 years old. And I have had an amazing, informative journey as his parent and continue to learn from him and learn from the people and experiences that he has introduced me to along the way. And I'm going to tell you a little bit about that as a framing for thinking about the work that I do. So from a pretty early age, Colin found it incredibly hard to attend the doctor's office, to go to the doctor's office for any one of a number of things. And this happened more recently, probably about 2-3 years ago, when we went actually to Packard and he was supposed to see a specialist. And we walked into the waiting room and the television was blaring a loud cartoon. The kids were understandably agitated, babies crying, toddlers crying. It was sensorily one of the hardest spaces for anyone to navigate. And I could tell right away that this was going to be incredibly hard for Colin, who was about 15 or 16 at the time. And fortunately, in our lives, we learned many years ago to plan ahead. And we have the great privilege of being able to have both my husband and I both take off of work when we took our son to appointments at that age. So my husband was able to walk him around the block. And I said, I'll sit in the waiting room and I'll let you know when it's time to come in. 45 minutes later, we were called back and he was already incredibly fried from the experience. And then we had to wait another half an hour in the waiting room. Now, I don't blame the providers for that. I think everyone's doing their best and we're all struggling, especially these days, with managing timelines. But for people like Colin with autism and other kinds of sensory difficulties, that kind of process can be incredibly difficult and can feel like someone blowing a trumpet in your ear. And the doctors, I think, are seen as not, and other healthcare workers are not seen as being very approachable and very understanding. I have actually still to this day never had an experience with a physician or any healthcare provider where they have really tried to understand autism and meet my son where he is. And that's really quite exceptional, seeing the number of really good and well-meaning providers that he has seen with me over the years. But this is the impression that I think many people with intellectual and developmental disabilities have when they go to the doctor's office or go to the emergency room. And so I think Colin has taught me that what we really need to do is provide scaffolding for providers and for patients to help improve the accessibility of healthcare for patients with intellectual and developmental disabilities. And I think of it a little bit like snow plowing. I think it's a two-sided bidirectional thing. I think patients and their help and their caregivers and advocates need to help thinking about how to advocate for themselves. But in addition, individual providers and systems such as Stanford and Packard have to actually build better systems for triaging and prioritizing the particular kind of, as Dr. Poulos mentioned, culturally competent care that's required, not just for patients with physical disabilities, but patients with intellectual and developmental disabilities as well. This is Colin right before the pandemic. He's actually become a pretty fierce advocate for himself, and he's minoring in disability studies. This is him actually giving a talk. He's given a bunch of talks to tech companies about how to be inclusive for people with disabilities. And about a year after that first appointment I told you about, we walked into yet another specialist at Packard, and we walked in. It was late in the day. The television was blaring. There was actually nobody else in the room. And he, without my prompting him, went up to the receptionist and said, "Hi, I'm Colin, and I have autism, and that sound is really difficult for me and makes me stressed. Could you please turn off the TV?" And the receptionist, to her great credit, did exactly that, and it was much easier for him. And I think that's an excellent example of how we can sort of think about the lived environment as well as our protocols and our approaches to understand what will make getting care easier for patients with intellectual and developmental disabilities. I like this quote from Tim Shiver, who is the head of Special Olympics International. He talks about how a need for inclusive healthcare that accommodates all patients with disabilities, and most of us will at some point have disabilities at some point, and certainly our family members will, is really an incredibly urgent priority. He says a revolution that says that inclusive healthcare is now the expectation, or dare I say demand, of the 21st century. The time is now, the urgency is high, the hope is big, our demand for change is immediate. And so I really like that quote. I also want to enter for a second about some of the examples of why we have to be inclusive and think about what we do. I actually just realized that I've made a mistake during this presentation of something I am learning and trying to do, which is actually providing audio descriptions of all pictures. I learned about 2 years ago that that's really important for some people with disabilities. And even though we have captioning and signing, that's actually considered to be a really important accommodation. And I failed to do that for the beginning of this. So I apologize for that. But I think that's a perfect example of accommodations that many of us may not know about, that are not hard to do, that we still make mistakes, and that having sort of cultural humility about the fact that we make those mistakes and trying to learn from them and improve in the future is really important. So I'm going to try to do that moving forward. I think one of my arguments that drives my work, that comes from my personal experience as a parent, is that people with intellectual disabilities and all people in healthcare settings need to be seen and heard and known. And I'm going to tell you briefly about 3 efforts that I'm involved in to try to actually do that through my work. The first one is the grant that Dr. Goldman-Ross mentioned briefly that we're about to get from PCORI, which is called IDD Transform, building a patient researcher collaborative for health research about intellectual and developmental disabilities. So as a part of this grant, we're focusing on researcher patient engagement and caregiver engagement, and we're focusing on 4 understudied areas for intellectual and developmental disability: emergency medicine, which is where a lot of people with IDD get their basic care, geriatrics and palliative care at the end of life, telehealth, and COVID-19 interventions, particularly testing and vaccination. There's a lot of data that shows that it's incredibly hard for people with intellectual and developmental disabilities to get access to both tests and to vaccinations, despite the fact, as I'll tell you in a moment, that they are at much higher risk of getting COVID-19 and a 2.5 to 3-fold increase of dying of COVID-19. And in fact, having an intellectual or developmental disability is the single highest risk factor for dying for COVID-19 in the United States. And as a part of this project, we're going to implement and evaluate methodologically rigorous and sustainable participatory approaches, so that's a lot of words, to soliciting input from adults with IDD across a range of communication abilities and demographics. I think many times people don't have the tools and the knowledge to know how to solicit and engage adults with IDD in talking about this kind of patient-centered research, so we're going to try and do that. We are very lucky to have partnership with Special Olympics Northern California and Partners and Advocates for Remarkable Children and Adults, which is an organization, a community organization that helps individuals and families with IDD in San Mateo County. And we're also going to create and hope to share with all of you who might be listening today a sustainable virtual forum for education, discussion, and engagement of stakeholders on these issues. And as Dr. Goldman-Ross mentioned when she introduced us, sorry for the typo there, I'm lucky, very lucky to be a co-principal investigator with her, and it's her expertise is going to be incredibly instrumental in helping us do this work. I also do a lot of work on rare and undiagnosed genetic disease and disability, and that's mostly as a partnership with the Undiagnosed Diseases Network Center at Stanford, which is run by John Bernstein, Matt Wheeler, and Ewan Ashley, as well as others. And it's also a collaboration and partnership with my colleagues at the Center for Biomedical Ethics, Megan Halley, Jenny Young, and Kevin Mintz. And I'm not going to have time to talk about all of our work, but I'll just mention one article which came out last year, which was a survey we did. It was actually a national survey about the experience of rare and undiagnosed families, many many of whom often with genetic diseases, many of whom often have significant disabilities, including intellectual and developmental disabilities and sometimes physical disabilities, talking about their challenges in getting care in the COVID-19 pandemic. We learned a lot of interesting things, and I think those are going to be informative. One of the things I think that's been true with people with disabilities with COVID is that, like so many other underrepresented groups and groups with health equity differences, COVID has simply magnified those and made them worse and exacerbated them. So there's a lot of work to be done. I'm also working with my colleague and postdoctoral scholar, Kevin Mintz. We submitted a proposal to study disability identity within the Undiagnosed Diseases Network about parental conceptions of disability experience and identity, and help understand how to better serve the needs of parents and their children and families who may be seeking diagnoses or may have rare genetic diseases and disability. And then the last thing I'm going to mention briefly is an initiative to try to work on education for medical students and PA students, actually, in the Stanford School of Medicine. Lauren Clark, who's a second-year medical student, started, and I'm the faculty advisor for a new chapter of the American Academy of Developmental Medicine and Dentistry at Stanford. And that's a student-led effort to do a lot of initiatives around IDD specifically. And partly through that, we're going to have a patient panel for first-year med students with adults with IDD. Sorry, it says first years twice there, in a couple of weeks. And we're very excited about that. We've actually never had, to my knowledge, an ability to have sort of pseudo-standardized patients for medical students to actually interact with the IDD. So that's going to be very exciting. We're also working with the Pre-Clerkship Directors Committee to try to integrate disabilities cases and best practices into other med school courses, and to try to follow the examples of some of the other efforts at intersectionality, as Dr. Suth had talked about, and think about how we can promote equity around disability in all of the existing courses that the first and second years take. And then I have the great fortune and honor to take over from my former colleague, Dr. Corey Paffenberger, the elective that's offered now in the spring of 2022, Caring for Individuals with Disabilities. We're always looking for more people to be involved with that. So if any of you are interested, please feel free to reach out to me. And I just like to end, I love this picture of a tapestry being formed. And when I think about what inclusive healthcare looks like for everyone, both people with physical disabilities, intellectual developmental disabilities, and those of us who may not yet or at this moment have those, I think of it like a tapestry where we can weave in the different threads and create something beautiful that actually is responsive and representative of everybody. And with that, I will stop.
Wonderful. Tremendous. Thank you so much, Dr. Tabor. It's so wonderful to add that dimension to our discussion today. So let's see. I think I'll ask everyone to turn their videos on so we can do the Q&A. I will get to the Q&A. So we had some questions. I was really struck by each of your presentations about